Hello, everybody. My name's Tiara Gill. I'm very happy to be joining today and being part of this exciting programme. And I'll be talking today about updates in pregnancy and lactation-associated osteoporosis, a rare condition which we're hearing more and more about, and thought it'd be useful to just share some more recent updates in the area. I'm actually a consultant rheumatologist. I work across two different trusts, and that's at the Royal National Orthopaedic and at London North West as well, so in the North London sector. So these are my disclosures. And just in terms of a rough overview of my talk, I'm going to sort of give a definition of what is pregnancy and lactation-associated osteoporosis, who it affects, why does it affect them, and the impact of the condition on women. And at the moment, what are our best management options and approaches to managing women with this condition? So firstly, as I say, defining it. Before I define it, I just wanted to quickly mention about what the changes are to bone metabolism during pregnancy and lactation. It's a significant period of altered bone homeostasis, and this is generally due to the increased calcium requirements, obviously needed by the growing fetus as well as the feeding infant. However, most women who are pregnant or breastfeeding don't typically experience low trauma fractures. So what is unique about this condition? In terms of definition, we characterise it by the occurrence of atraumatic or fragility fractures during the last trimester of pregnancy or in the postpartum or lactation period. As I mentioned before, it's rare, although because studies are so limited, the prevalence of PLO is actually very unclear. Some studies have tried to estimate it, though. A Japanese group tried to estimate it in terms of their total live childbirths, and they estimated it around 460 cases per million, and this was only published last year. And in the UK, again, a Scottish group have also tried to estimate the incidence back home, and have estimated this to be around 6.8 per 100,000 pregnancies. Tends to predominantly affect women in their 30s, although the range can be anywhere up to late teens, up to late 40s. And studies that have been done have reported that it's predominantly affecting Caucasian women, although I would argue, given the limitations around a lot of the studies in terms of numbers, I'm not sure how well documented ethnicity has been. It does predominantly affect women in their first pregnancy, so 70% of patients with PLO, they are preniparous. Before we actually talk a little bit more about PLO, again, I thought it'd be useful to go back and look at the physiological changes a little bit more detail during normal pregnancy and lactation, what is actually happening to the skeleton during this time. So firstly focusing on the left-hand side of the page and looking at in a pregnant woman, there is lots of changes that generally increase the intestinal calcium absorption, and this is generally mediated by increased secretion of parathyroid hormone like receptor peptide, PTHRP, which is secreted by tissue. So that's placental tissue, breast tissue, and you get increasing circulating levels in the blood, which increase absorption in the gut, as well as mediate and facilitate placental transfer to the growing fetus. This is obviously going to increase our calcium levels within the serum, and therefore correspondingly the PTH levels that are normally secreted by our parathyroid glands, that decreases. Because of the increasing circulating calcium levels, you get increased urinary calcium excretion and increased bone turnover, although this goes from predominantly a resorption phase in the first to second trimester to an increased bone formation phase, which is reflected in the increasing P1NP levels, which peak at the third trimester. You get corresponding decreases due to all of these changes of drop in spinal bone density, quite significant drop actually of nearly 5%, as well as decrease correspondingly in the hip as well. And that's all just happening during pregnancy. And then moving on to the lactation phase, you do get some changes to the altered physiology that I've just mentioned. So the calcium absorption tends to level out a bit, and it normalizes to pre-pregnancy levels. Because of the reduced calcium absorption, PTH levels start to go up, and even more increasing levels of PTH-RP due to increased mammary tissue is secreted. Decreased urinary calcium excretion, and this is because the calcium which is circulating is actually getting transferred to the breast milk and to the feeding infant. You have corresponding increased bone resorption, but bone formation markers as well. And as I say, ongoing loss at both the spine, which is more pronounced in the lactation phase than it is in the pregnancy phase, up to 7%, as well as the hip. So this was summarized really nicely in this diagram, actually. Is from a lovely mini review that Agak et al. Published only last year. So moving on to sort of the risk factors for why this may develop and who is going to be more affected or likely to be affected. This is all very speculative at this stage in terms of what we think are the contributory factors and why some patients may be more susceptible. But these are sort of the most common theories that have been proposed. So there is a school of thought now that actually women who develop PLO probably may have a pre-existing low BMD to start with, although we're not really able to establish this because nobody has a bone density scan until there is an issue. So they may not have a baseline scan that you'll be able to say pre-pregnancy they had a pre-existing low bone density, but this is what's been postulated. And some genetic studies have suggested that the genes LRP5 or 6, as well as the Wnt1 pathway genes, may well be implicated in this. And we know these genes from sort of other primary bone disorders that we manage, because there are genetic mutations in these genes for other primary bone disorders. This may also be an opportunity as our first presentation to diagnose a primary bone disorder, which up until this point hasn't been picked up. And the fracture during pregnancy is the point when they may well lead to a diagnosis. Mechanical factors are implicated for development of obviously these types of atraumatic fractures. For example, if you've got low peak bone mass, which you've not developed during sort of normal development, you are, with the extra load, be more susceptible to fracture. If you have a low BMI, we know this is a risk factor for osteoporosis in general, and that may also lead to extra strain during pregnancy, as well as ligament laxity, which can lead to sort of altered biomechanics. Underlying hormonal abnormalities such as parathyroid or gonadotrophin or pituitary disorders may be underlying as well and not being diagnosed previously, or they may have a pre-existing diagnosis of them, which may also predispose them to developing a fracture during pregnancy or lactation. Renal disorders, especially ones where you have renal calcium wasting leading to reduced calcium deposition within the bones, may also be implicated, as well as some rheumatological disorders where you've got, let's say, connective tissue issues. Ehlers-Danlos syndrome again might lead to altered bone structure, as well as connective tissue disorders where you have ligament laxity. Nutritional deficiencies may well underline some of the baseline bone issues that these women may have, and that could be due to low supplementation of calcium or vitamin D, as well as absorption or malabsorption issues, whether it's due to inflammatory bowel disease, celiac, or eating disorders. And then pharmacologically, there may be iatrogenic causes that may may lower bone density. We all know about the steroid effect on bones, and as well as other drugs such as anti-epileptics, which alter bone quality, and this may also be in the background before someone develops a fracture during pregnancy. Some more recent work has suggested, and this is a rodent study that was recently published in Nature, that there is also other hormones or proteins that may be secreted, and CCN3 is a hypothalamic peptide that is secreted and may well be implicated in normal sort of bone metabolism. And what's been suggested is that increased CCN3 levels may well protect the maternal skeleton during lactation, reduce bone resorption, and therefore may well play a part. But this is still very much work in progress at this stage. I thought I'd mention it. So moving on to clinical presentation. This is notoriously, if we look at the population of women that are affected by this, one of the key things that you see time and again is that there has been delayed diagnosis, and that's because the symptoms can be vague, non-specific, and variable in onset. Vertebral fractures are the most common presentation, but this can present as either an acute onset of back pain or more insidious gradual onset. But other signs may be that they have reduced mobility, there may be a loss of height, which could also signpost you to thinking, has someone had a fracture in the spine? As I mentioned, this is the most common site of PLO in terms of fracture site, and this correlates as well with what I'd explained earlier, in that bone loss is predominantly affecting the spine compared to other sites, although other fracture sites have been reported, including the hip, sacrum, humerus, and ribs. Spinal PLO is the most common form, however, but there is another debilitating form called transient osteoporosis of the hip, which is pregnancy related. So I thought I'd just quickly touch on this, because this may well be something that we see. This is usually typically in the immediate postpartum period or in the third trimester of pregnancy, and will present much more discreetly than maybe spinal fractures, in that women who have reported or been diagnosed with this report a sudden onset of severe non-traumatic hip pain and significant reduction in their hip movements and mobility, which alerts people to investigate. In terms of what is underlying why somebody is developing this, again, sort of theories suggest that maybe mechanical stress caused by the growing uterus compressing the iliac vein might increase venous hypertension, increase intramedullary bone pressure, and therefore lead to elevated bone turnover. And also there may be pressure on the obturator pelvic nerve, which may also trigger bone marrow edema and make the bones not very happy. In terms of management, offloading is advised to reduce the risk of possible imminent hip fracture if they haven't fractured already. However, this does tend to be self-limiting, with resolution of symptoms and bone marrow edema within 2 to 6 months of delivery. However, recurrence has been reported in subsequent pregnancies, so something to watch out for once somebody has had a diagnosis. So moving on to investigations. Goes without saying, I mean, the first thing we do when we diagnose is obviously image the site of interest wherever the woman is reporting pain or symptoms. But I would also suggest that if, for example, it's a hip pain, that the spine is also imaged, because there may be, as we do see with postmenopausal osteoporosis, affected as well, because this will, in terms of prognostic factors, it's important to establish the extent of the fracture. Bone densometry is the next step. You need to do some measurements of the bone density more formally, and I'll go on to talk about this in a little bit more detail later. As I've already mentioned, secondary causes should be screened for, including obviously thyroid function, gonadotrophin, pituitary axis, etc. Urinary calcium phosphate as well as creatinine is important to look at for wasting sort of conditions. And as I mentioned already, genetic panels may well be useful in trying to diagnose whether someone has a premorbid genetic cause that has predisposed them to fracture. Bone turnover markers can well be useful, and that could be measured in serum or urine, although it's difficult sometimes to gauge at the time, especially if somebody's had a fracture. The bone turnover markers are going to be elevated, but it may be useful as a baseline if you are starting some treatment or you're trying to monitor what is happening to their bone turnover over time. Okay, so looking more closely at how we measure bone mineral density in this condition, as I've mentioned, this can be difficult because of radiation exposure and the concerns around it during pregnancy. However, there have been some studies that have looked at measuring bone density pre and post-pregnancy, and this did show that over that 9 to 10 month period, women can lose up to 4% at both the lumbar spine and the hip. And so we can see, again, this echoes what we've already discussed in terms of average bone loss. And there's been another study as well that looked at sort of what is the absolute scores, the absolute Z scores at this time as well. And the average was found to be around -3.5 at the lumbar spine, which is well below the normal expected bone density for women sort of around their mid-30s or younger. There is a direct correlation between the duration of breastfeeding and postpartum amenorrhea, as we would expect, as estrogen is so protective of the bones. This then correlates with the level of BMD decline. And quantitative QCT, as well as peripheral QCT, there has been more work recently done on this, and this is providing additional information other than obviously just bone density readings obtained via a standard DEXA scan in terms of the cortical and trabecular bone structure. So this is looking at the microarchitecture of the bone, and this lovely review that was written a few years ago has shown some pictures of this, and we can see, for example, this is the radius, A and B are the radius or radii of a lactating woman with PLO on the left, as well as a normal sort of the bone of a woman who hasn't got PLO and is breastfeeding, as well as, again, the tibial cross-section in panels C and D. Again, you can see the microarchitecture on the left is, you can see large spaces between the trabeculae, and the density overall doesn't look as high as it does on the panels on the right. So this is something I think that is going to in the future help us understand better what is happening on a sort of architectural level within the bone that may predispose patients to fracture. So moving on to management of PLO, there is no guidance, whether nationally or internationally, about what is the optimal type of treatment or duration of treatment for patients that have a diagnosis. The key thing, though, and the most important thing is, given that a lot of the bone loss happens when breastfeeding, that to avoid lactation or to breastfeed for the shortest amount of time to promote recovery and prevent further deterioration is one of the key elements of your strategy. This can be difficult for women because there is a lot that is, sort of in terms of catchphrases around breast is best. It can be an emotive issue for a lot of women, so this must be approached sensitively, but is obviously very crucial to their recovery post-fracture. Calcium and vitamin D supplementation is really key, and I'm going to talk about that in a little bit more detail in a minute. There are pharmacological options that are evolving, which I'll touch on. Physiotherapy is very important. The issue around mobilizing early and making sure women are not fearful to move is going to be very, very important to their recovery. Surgical treatment options, they're rare. Very few women have unstable fractures that require surgical intervention. However, there were a few case reports that I came across where women had suffered from cauda equina or unstable fractures that required some form of surgical intervention, but this is rare. Psychological support is really important for these women, and I will talk about that again in a bit more detail later. And then it's really important to think about planning and counselling for future pregnancies, because the majority of these women, this will have happened in their first pregnancy, but this will have implications for further family planning. So observational approach. There is a school of thought that says that the physiological recovery following delivery or weaning from breastfeeding it may be sufficient actually for recovery of bone density. And there have been some studies showing that when you follow women sort of up to a few years after postpartum, they have quite significant increases in their bone density. And this usually is because they have resumed their menstrual cycles and they have and their bone turnover has normalized. So there is sort of a school of thought thinking that we should maybe just manage them conservatively and observe and ensure that they are getting adequate amounts of calcium and vitamin D supplementation. However, if, as I've mentioned before, your baseline bone density is really low, will just supplementing with calcium and vitamin D build the bones up to a point where they are less liable to fracture in the future. And again, it's been proposed that maybe a repeat bone density scan 6 months after weaning may help guide your decision as to whether you would like to escalate to other types of pharmacological treatment. So that may be a way forward. So in terms of pharmacological options, we have all the standard armamentarium of what we use to treat osteoporosis, starting with bisphosphonates. Studies have shown they have reasonable efficacy when you have weaned and can result in up to 15% bone density increase when you treat after somebody has had a fracture and they have stopped breastfeeding. The teratogenic effects are not clear in studies, but so we tend to advise women not to have bisphosphonate exposure either pre-pregnancy or if they're planning future pregnancies, and obviously not during the breastfeeding period. We know the skeletal half-life of bisphosphonates is very, very long, and this is the main reason we advise against it. Although, as I've mentioned, it does have good efficacy. Denosumab, which is a rank L monoclonal antibody and works very well at decreasing osteoclastic activity, and therefore is a potent anti-resorptive. Also works very well, and have been some case reports, and these graphs on the right show one case of a woman who had spinal fractures and very low spinal bone density demonstrated by the red line. You can see that she, over time, as she had started denosumab, and she had it for about 18 months, she had significant increases in her spinal BMD. However, this had to be discontinued because she was planning, another pregnancy, and therefore this did deteriorate. And this is something that we know we expect with denosumab cessation, that you get this drop, especially in vertebral bone density, which can result in fractures. So this is a concern that we have obviously with denosumab use. However, you can see she went on to get pregnant again. She had no further fractures, and actually her spinal bone density never went back to the baseline that she had pre-DMAB treatment. And so this may be something that we should be thinking about, especially as the half-life and the washout is much, much shorter than it is for bisphosphonate treatment. So this is something to consider. It is showing efficacy in this space. Teriparatide is a osteoanabolic agent, which again, we are using more and more of in the osteoporosis space for postmenopausal women. It's a synthetic PTH analog. And a systematic literature review that was only published last year showed 2 studies where, again, in terms of using this versus just standard calcium vitamin D supplementation, these forest plots show that both at the spine and the plot on top, as well as the hip, they had better outcomes than just standard supplementation with vitamins or calcium. So this is an emerging therapeutic option, which I think a lot of people are considering would be useful for pregnancy-related osteoporosis. And this paper that was published again last year, it summarizes sort of the efficacy of the various treatments. This is a meta-analysis looking at the various studies looking at the different agents used in the PLO space. And the key things I just wanted to say that the graph on the left is showing spinal bone density, and the graph on the right is showing the hip. And the agents that are showing in terms of the greatest increases in BMD are, as I've mentioned, teriparatide in the purple line, as well as denosumab in the black line. So there are newer osteoanabolic agents such as romosozumab. There is very limited, even more limited evidence for this for PLO patients, although there was again another study published last year, which was a retrospective review of 25 women that were randomized to, sorry, not randomized, they were split into different groups in terms of analysis of their bone density when they'd had romosozumab, and there was a control group of drug-naive patients versus groups of glucocorticoid-induced osteoporosis, idiopathic osteoporosis, and PLO patients. And again, these plots are showing that, especially at the spine, the Romo group are showing much more significant increases in bone density. Again, this is mirroring what we see in the postmenopausal population. And therefore, again, this may well be a good therapeutic option to use in the future. In terms of recovery from a PLO-associated fracture, this is slow. The majority of patients, nearly 2/3 of patients over the next 3 years, will experience chronic pain. And this really can be quite significant in terms of impact on their newborn, on their family, on themselves as individuals. They have limited mobility, they may be in pain, and this can increase rates of anxiety and depression. And as I mentioned earlier, the delayed diagnosis, which is very common in the stories of these women, may well add to additional anxiety in terms of, whether if they have another fracture, how will they know? Back pain is very, very common, or hip pain or general musculoskeletal pains are very, very common during pregnancy and after pregnancy. The anxiety level you may feel once you've had a fracture that you're going to fracture again is really high and shouldn't be underestimated. So really important to screen for psychological morbidity and refer on to appropriate services. The prognosis for these women, some studies have estimated that could be up to 1/5 of patients have recurrence in subsequent pregnancies. And this is increased if they've had more than one fracture at the time of diagnosis. So that's why it's important to map the extent of their fractures at the time that they're diagnosed. This was mirrored in another series, which showed that, again, 2 out of 7 women had a new fracture within 36 months when they had experience, when they had previous diagnosis of PLO. So this is really important in terms of pregnancy counselling. And we might want to think about giving some of these bone-specific treatments, for example, the anabolic treatments in between pregnancies to build up bone density, as I mentioned or demonstrated in that denosumab patient, because this will build up the baseline bone density to a point that this may minimise future risk of fracture. So in summary, this is a rare condition, but is it as rare as we thought? I recently went to a presentation where they looked at PubMed searches 10 years ago on PLO, and they came up with 5 papers. And then last year, there's over already 250. So there is growing interest and awareness of the condition, and we should have an index of suspicion for any pregnant woman or breastfeeding woman who has persistent pain in any joints, in any bones. Back pain, height loss, loss of functional mobility are things that we should be investigating if that is what a woman is reporting. The evidence for osteoanabolic treatments is growing, but more studies are definitely needed. It's very limited at the moment. And as I've mentioned, the impact on women and their families is really significant during a life milestone. It's supposed to be a happy time, and then they're diagnosed with fractures. And so the psychological impact shouldn't be underestimated, and it should be acknowledged. So thank you for your attention.